Dr. Adel Hussein. He's gonna teach us in the next 30 minutes about antibiotic and sepsis, when, what, and how. Dr. Adel is a graduate from Cairo University in 1992. He's obtained his master's degree in 1997 from Cairo University. He completed his MD degree from Cairo University as well in 2002. He's a former assistant professor of critical care medicine, Cairo University, and he's currently working in critical care as a critical care consultant in King Abdullah Medical City in Mecca, Saudi Arabia. Please, Dr. Adel, feel free to.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف خلق الله والمرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. First of all, I have to appreciate and to thank Professor Saad Mahdi and his colleagues, the organizers, the moderators, all panelists, Professor Al-Ansari especially, for giving me this opportunity to be with you tonight. I hope my title will fit for the 30 minutes frame. Though it's difficult to cover or to highlight the antibiotics in 30 minutes, but I will try my best. And please accept my apology if I skip some slides because of the time frame. So the title is for this presentation is the antibiotics in sepsis, when, what, and how. I have no relevant relationship with any commercial or non-profit organizations. This is the objectives of my presentation tonight. I will give just a short overview, first of all, then I will highlight the important pillars of the antibiotics coverage in sepsis. First is the appropriateness of empirical antimicrobial therapy. Second is how to achieve the goal of timely antibiotic administration. Third is the dose option. Fourth is the combination of antibiotic therapy in sepsis and septic shock. Fifth is the duration of antimicrobial therapy. Next is the de-escalation of the antimicrobial therapy. And lastly, is the use of biomarkers to guide the antimicrobial therapy in sepsis. And I will sum up with some take-home messages. Let's do sepsis the problem. Of course, sepsis is a public health problem. It carries a high mortality. It comprises about 12% of total ICU admissions. And of course, in each country, its burden of death 3 times those of the national road toll. Commonly, we have sepsis pitfalls. So please, to increase the awareness, try to avoid the pitfalls. What's the common pitfalls is the failure of recognition, failure of early detection, underestimation or underappreciation of the ICU mortality, and also failure to respect the sepsis syndrome as time-critical illness. Of course, all of us working in trauma or CCU, we are neurocritical care. We have 3 codes: the hospital, trauma, trans to mortality. The overall mortality from trauma is about 7%. For STEMI, is about 5%. This is overall mortality. The stroke is about 8%. Okay, what about the septic shock mortality? Treble or quadruple, it's about 25%. So if you have a patient admitted alone with septic shock, not with multi-organ failure, not with ERDS, just for septic shock, it's about 25% mortality. So we are underappreciating, we are not having a septic code or sepsis code. What are the common reasons for litigation and sepsis care? And this is very common when you have a medical legal issue regarding sepsis care or sepsis management. First is the failure to recognize sepsis, delay in management, like delay in triaging, nursing assessment, door to doctor, ancillary services. Those are results or can result in delayed treatment and bad outcome. Failure to aggressively resuscitate with the fluid, as Dr. Hisham said in his lecture, too little or too late or not at all. Failure to administer early, appropriate, and broad spectrum antibiotic, which is the core of my presentation tonight. Failure to consult the critical care team, failure to monitor and to treat the decompensation or the sequelae of sepsis, and lastly is the failure to admit to the appropriate level of care, or failure to disposition to appropriate level of care. So if you ask me what are the challenges to standardize the sepsis management, this is a worldwide question, and this is one of the major concerns. Till now, you cannot standardize the sepsis syndrome management. Why? Your patient is having multiple comorbidities, plus the infection, the immune response, the physiologic derangement that results from those sequelae, and overall, or the sequelae of organ dysfunction. So those challenges led to unavailable standardization and the sepsis management. Yes, you have the best available evidence, but till now you have those challenges you cannot overcome one by one. As Dr. Hisham said, I will not go through. This is the 1 hour model, the common diagram for initial resuscitation and septic shock. It's a very famous one from Surviving Sepsis campaign. This is the components. I will not go through also. Just quickly reminder, and for someone of the attendees was asking about the critical lactate level, is the lactate more or equal than 4? So this is your target, and you re-measure if the initial lactate was more than 2. But for you and the 1 hour bundle, your cutoff is more or equal to 4. So the messages from the Surviving Sepsis campaign, as all we know, just I would like to highlight those 4 pillars that you should act upon sepsis recognition, so time is counting. Second, you have to minimize time to treatment in sepsis and septic shock, because both of them, we call it medical emergencies. So you should behave the same like you are behaving in the trauma or the STEMI or the stroke. Third, you should monitor closely for response to intervention. And fourth, you should communicate the sepsis status in hands off for your colleagues and for the multidisciplinary team. If I will highlight the initial resuscitation hour 1 bundle, as Dr. Hisham said, I will not go through all components, but just to highlight for those 5 components, it's like a bundle. You should not ignore one. You should use it as a bundle. So measuring lactate, blood cultures before the antibiotics, giving the broad spectrum antibiotics, giving the IV crystalloids when indicated, use the vasopressors when indicated, and end up with reperfusion assessment, which is it's very important. So my core tonight is about the broad spectrum antibiotics in sepsis and septic shock. So before moving antibiotic or the blood culture, Hisham already said, just I would like to add this slide. Why usually we recommend, or the Surviving Sepsis campaign recommend 2 sets of blood cultures. First is because of the incorporation of matching sets. It confirmed the treatment of true pathogen, not a contaminant. This is why we use 2 sets, not 1 set. The goal is to prevent culture negative sepsis and septic shock. Out of 6.8 or 7 million septic shock admissions, almost close to 47 to 50% were culture negative. So you can imagine about 50% of sepsis, septic shock, they are culture negative. So culture negative sepsis, septic shock was seen as statistically significant independent predictor of death. So remember this very well, about 50% of your patients are culture negative, and adding to this, they are independent. This is independent predictor of death. So if you have patient with septic shock and you hosted your cultures survey, then you end up with culture negative septic shock. This is a significant predictor of mortality. And measuring the hour 1 bundle is very important to know where you are standing. Are you succeeding? Are you compliant with the 1 hour bundle? So this is a study measuring the sepsis score measures and why they fail to be compliant, and where it is the components of failure. So here is the lactate measurement, repetition. Here is the fluid administration less than 30, antibiotic administration more than 2 hours, lactate result in more than 3 hours, blood culture drawn more than 3 hours. So this is the failure of the sepsis score measures analysis. This is your rule when you apply, just not to apply, just to monitor your sepsis score measures, when you succeed, when you fail, and why you fail, and what mainly component. Is it the blood culture? Is it the antibiotic delay? So this is very important when you monitor with your quality, with the administration, the sepsis score measures. Do really the minutes matter in sepsis resuscitation? Is it really important? To answer this question, the Society of Critical Care Medicine published a retrospective cohort study about 5,000 patients in severe sepsis, septic shock. Majority of patients had the 3 hours bundle recommendation, the before version, the previous version, initiated within 3 hours before 2016. In hospital mortality was 27% with those people who applied or they were compliant with the 3 hour bundle recommendation. But they analyzed the time frame from within the 3 hour bundles and what are the components. We call it sepsis score measures. So the time after which the delay, they found that there was an increased risk of this. Lactate reached 20 minutes to get it. Blood culture, 50 minutes, close to 1 hour to get it. Antibiotics exceeded 2 hours, and giving the crystalloids, the appropriate IV fluids, exceeded 1 hour. So the guidelines recommendation showed that shorter delays indicate better outcome. Why? Because minutes matter. There was no evidence that 3 hours is safe. A very short delay adversely impact the outcome. The antibiotics, as all we know, are the life-saving treatment in sepsis and are the single most effective treatment we have for sepsis and septic shock. The longer treatment is delayed with giving the antibiotics, the higher the patient risk for mortality rises, of course. And since 2001, 2006, from Kumar et al., which was the classic study that we rely on the timing of antibiotics in septic shock, every 1 hour antibiotic initiation is delayed. This is, of course, increases the risk of mortality up to 8%. Antibiotics in sepsis and septic shock, like everything else in life, timing is everything. And this is a graph that translates what we said, that for every 1 hour delay in antibiotics, there is an increase of mortality up to 8%. So the most important thing you can do for your septic patient is do not delay the antibiotic administration. And this is a study also since 2000, a famous one from 2007. It correlates the early initiation of appropriate antibiotic therapy in septic shock and its relation to survival. And here, as we can see, the relation between the antibiotic, the overall survival correlated to the early antibiotic administration. The delay in antibiotic administration is increased with a mortality rate and lower survival rate. So every time you delay the antibiotics, here you give it at 1 hour, here you give it at 12 hours antibiotic, for example, or here at 6 hours, for example. So the survival rate is the mortality rate is increasing as far as you are delaying the antibiotics. Also, another translation, this is the delay of antibiotics of the first dose in sepsis and septic shock, and this is correlates with increasing mortality up to 45 to 50%. Antibiotics should be given as soon as possible, but when? After blood cultures are drawn, preferably after the second set of cultures. This is usually what we recommend. So usually give the antibiotics after blood culture, so do not delay the blood cultures. Try not to delay. Preferably, you give the antibiotics after the second set of cultures. However, if the second set is going to be delayed more than 30 minutes, antibiotic should be started after the first. This is an exception. If more than one antibiotics is ordered, like you use combination of antibiotics, give the broadest spectrum antibiotic first. For example, if you're going to use one of the beta-lactams or one of the carbapenem, so this should be given first. And infuse multiple antibiotics concurrently if appropriate. Always give the antibiotics with the shortest run time first without delay. Give the antibiotics with 30 minutes infusion time at first, like STAT. So STAT definition, less than 30 minutes, the antibiotics should be given. Then give the one that is infused over 1 or 2 hours infusions. So for example, if I'm gonna use vancomycin, you cannot give it a short run, not a bolus, but you have to give it as infusion. But for other antibiotics, yes, you can use it, the STAT one as push and with the shortest run time first. Give the first dose. This is very important, and we face it many times in the ER or in the ICU that the patient has renal failure or chronic liver disease, and we are adjusting the first dose. So the first dose usually, even if it's an end-stage disease, chronic liver disease, does not need an adjustment. Give it full dose. For example, Beptazo, give it 4.5 from as a full dose without dose adjustment. Then adjust later on. For meropenem, you're gonna use 1 gram or 2 gram. Give it the full dose from the start without adjustment, then adjust from the next dose based on the creatinine clearance or the liver functions. So how long does it really take to administer the antibiotics? Yes, they studied this, and there was 3 RCTs: the ARISE, the PROCESS, PROMISE. All of you know about it. The median delay of the antibiotics from arrival in the ED to ER, not from the diagnosis of sepsis. This is a very controversial point, which you want to calculate from arrival to ER or from sepsis diagnosis. Better or evidence-based wise is from sepsis diagnosis. So here in those are the 3 major RCTs. The median here was about 70 minutes. With the PROCESS trial, was majority within 3 hours. With the PROMISE trial, the majority, or the median was about 2.5 hours. All of us, we know what's the rationale behind giving early antibiotics. I will put the slide, but I will not go into details. But usually the mortality is not necessary. What is important to mention here is the mortality is not necessarily caused by infection itself, but the physiological response to infection and multi-organ dysfunction is very important to know about it. And your early antibiotics is to halt or to ameliorate this physiological progression to multi-organ failure syndrome. If you want to dissect what are the common reasons behind antibiotics delay in the ER or in the ICU or in the floor when you assess, for example, RRT or SAT team or sepsis code. So we found that there is system level factors. We found patient level factors, and we realized about presentation level factors. For system level factors, ER crowding, inadequate staffing, as the Dr. Shaman before in his presentation, delays in diagnostic testing, patient transfer, internal policies that interfere with early administration of antibiotics, like anti-stewardship program or approval from IDT. Those are system level factors. What are the patient level factors? The age and the comorbid condition that predispose patient to having atypical presentation, like in elderly people, immune compromised. So there was atypical presentation that's underdiagnosed or underestimate the presence of sepsis and delaying, of course, antibiotics. History of drug reactions, difficult IV access, those related to the patient himself or the host. What about the presentation level factors? The atypical presentation, of course, like, as we mentioned before, like in elderly people, like in immune compromised, the atypical presentation leads to delayed diagnosis, the evolution because of the evolution of clinical symptoms, signs and symptoms, the ability to recognize clinical features, the requirement for further diagnostic tests like imaging. The goal everywhere in the ER or in the floor or in ICU is to stop the infection, but antibiotics alone are not enough. Source control has pivotal role in sepsis management. It is something need the core of 4Ds of source control. So please do not delay. I will not go quickly for this because my colleague, Professor Hassam Afifi, he will highlight probably, and you will enjoy how he will address the source control. So for the antibiotics, the appropriate antibiotics, yes, are essential. But until the organism is identified, broad spectrum antibiotic treatment is necessary to cover most likely the sources. Source control usually is the key to stop inflammatory response and the cascade of the systemic dysregulation. So the core of these of source control, 4Ds. Every time you face patient with sepsis, septic shock, confirm a diagnosis, ask yourself about the 4Ds. Drainage for any collection or loculation, debridement for any soft tissue infection, device removal for any lines, central line, big line, permacath, and definitive measures for surgical intervention if you have bowel ischemia, perforated viscous. So those are the 4Ds for source control. And remember the mantra. The mantra for timing of antibiotics for sepsis is to hit 3: hard, early, and appropriately. And this is the therapeutic ladder of antibiotics in sepsis: the appropriate therapy, the adequate therapy using the timing, the penetration, the pharmacokinetics and pharmacodynamics, and the optimal therapy. Then how to reach the optimal antibiotic therapy? Through when, what, and how. So optimal antibiotic therapy, you should have adequate timing. This is when to start. Then adequate duration, when to stop. Then what's the adequate coverage? What organisms you're gonna cover? This is what. What's the correct route? So this is BO or IV. Of course, for septic patient, you are relying on IV. So this is how. For what the correct dose and pharmacokinetics and pharmacodynamics that affect your antibiotics, this is how much. What is the correct administration, prolonged infusion, extended infusion, this is how. And what are the immunomodulatory effects? Those are the components that determine the optimal antibiotic therapy. For the antibiotic therapy timing, so this study in 2014 published in the Critical Care Medicine Journal. So the conclusion of this study that the analysis of large population with sepsis or septic shock demonstrate that delaying the first antibiotic administration was associated with hospitality. In addition, there was a linear increase of risk of mortality to each 1 hour delay of antibiotic administration. There is results of underscoring the importance of early identification and treatment of septic shock and awareness in the hospital settings. Also, you need to have an evidence. A lot of evidence are accumulating since long time. A patient with severe septic shock, he should receive early and appropriate antibiotics in the ER or in the floor if you are managing the rapid response team. Patient with septic shock who received the appropriate microbial therapy within 1 hour of recognition had greatest benefit in mortality. As Dr. Hisham said, that there is a Belton et al. In 2019 reported that there is no mortality benefit of administering antibiotics within hour. Of course, this was a study published in 2019, but there is a lot of criticism for those data in 2017 and also one in 2020. regarding the study design, regarding the antibiotic administration appropriately, and the non-infectious source, as Dr. Sham said. Regarding the pharmacokinetics and pharmacodynamics, those are usually the physiologic alterations that usually affect the pharmacokinetics and pharmacodynamics of the antibiotics in sepsis. So in sepsis, usually the volume of resuscitation, the capillary leak syndrome, the hypoalbuminemia, those lead to increase the volume of distribution. For sepsis, because of the hyperdynamic circulation, we have high cardiac output status. This elevates the clearance of the antibiotics and medications. This is, of course, combined with the capillary leak, the hypoalbuminemia, with the increase of distribution, it will lead to low plasma concentration. So you have to be aware about this. On the other hand, if you have sepsis, septic shock with its sequelae, which is the organ dysfunction, renal failure, liver failure, this is, of course, will decrease the clearance and, of course, will lead to high plasma concentration. This is the effect of administering problem with different routes, like with different protocols, intermittent infusion, prolonged infusion, or continuous infusion. If you look here, the lowest required dose to reach the 2 milligram per liter for volume distribution, it was the best with the continuous infusion. Intermediately was with prolonged infusion, but here with intermittent, you need 4 to 6 grams to reach the lowest dose, or when we reach the MIC or battery MIC. So better with prolonged infusion, much better with continuous infusion. I will just skip those slides about, though it's important, about the augmented renal clearance. So what does it mean if you are in doubt about MDRO's organisms as the most likely of the sepsis, and you have a normal or high renal clearance? So here you hit with stents, or you hit to broader. If you have a nice resistant pattern of antibiogram, patients have renal function start decline, so you have to decline or to narrow your antibiotics. They demonstrated in this study the demographic and therapeutic and illness severity for those with augmented renal clearance, and they found those patients usually are young males with normal serum creatinine. What's the effect of obesity on population? Pharmacokinetics and pharmacodynamics of probenum administration critically ill. Obesity, it increased the volume of distribution. Of course, it affects the PK/PD parameters. But they found, although the obesity was found to be associated with increased volume of distribution, dose adjustment and creatinine clearance appears to be important more than the PMI. So again, you have to address and to respect association, or respect and appreciate the creatinine clearance and augmented creatinine clearance. This is the pattern how important is using the loading dose. If, for example, if you are using antibiotics like meropenem or colistin, so for effective concentration, the loading dose usually is not affected by renal function as a stat dose. So this is very important when you are giving a drug, or antibiotic like colistin. You have to use the full loading dose, like 9 millions or more. This is a nice meta-analysis. It compared the continuous versus the intermittent beta-lactam infusion in severe sepsis. And here it is translated into a favorable outcome for both in-hospital and ICU mortality with the continuous infusion. While here is the mortality Kaplan-Meier curve shows the 30 days mortality reduction with using the continuous infusion of antibiotics compared to the intermittent. So they concluded that compared with the intermittent dosing, administration of beta-lactams antibiotics by continuous infusion in critically ill patients with severe sepsis, septic shock is associated with decreased hospital mortality. There is an ongoing trial called the BLINK-3 trial. This is an ongoing prospective, multi-center, open label phase 3 RCT. They are comparing the meropenem or beptazo, either intermittent or continuous infusion. What they are aiming for, they are comparing the effect of the 90-day mortality, beta-lactams, antibiotics, beptazo, or meropenem, administered either continuous or intermittent infusion in a large patient population, about 7,000 critical ill patients with sepsis. It's not published yet because it's still an ongoing trial. What about the therapeutic drug monitoring? Is not the core of my lecture tonight, but just to brainstorm you when you go back about the TDM. How many of you perform TDM of beta-lactams, which is very important part of research, part for clinical practice? And still do we need RCT? I agree. So to conclude with this, start antibiotics early. We likely never have a definitive evidence. Start with loading dose. If no doubt on MDROs or high renal clearance, normal renal clearance, I mean, aim for higher than normal dose. If you can, monitor what you are doing, which is very important, and adjust according to that. Evaluate and stop antibiotics time. What about the advantage? The other part or the other pillar of the optimal antibiotic therapy, adequate coverage. Should we appreciate the problem magnitude? Yes, we should appreciate it. Why? Because the prescription of inadequate empiric antibiotic therapy is prevailing. The incidence is up to 40% of cases they are not receiving adequate empiric antibiotic therapy. Depending on the incidence of MDROs, pathogens, and the degree of adherence to clinical guidelines, the coexistence of delay and efficacy of the treatment has been associated with low survival rate. This is, of course, because you are delaying the antibiotics. And here is worldwide, up to 40% of cases of patients with septic shock in the ER or the rapid response or the ward or in the ICU, 40% of they are not using, they are not receiving adequate empiric wide spectrum antibiotic therapy. For many reasons, as we mentioned before. So how to select an adequate empirical antimicrobial therapy? Adequate is to cover all likely microorganisms causing suspected source of infection. So if you are facing patient or host that is immune compromised, or you should think about your antibiotics to cover the most likely organisms. We group it into three major important factors that can help to use or to choose adequately the empiric antimicrobial therapy in sepsis. Patient-related factors, pathogen-related factors, and local antibiogram chart. Patient-related factors, age, weight, allergies, the comorbidities, the underlying chronic organ dysfunction like renal failure, liver failure, immunosuppressive therapy, and history of recent exposure to antimicrobials. For pathogen factors, the risk of multi-drug organisms or the risk for invasive fungal infection. So you should review your patient about prior antibiotic exposure, prolonged hospital stay, recent hospitalization, the presence of lines, invasive lines, local ecology and resistance, which is related to local histobiogram, and the previous colonization by resistant pathogen. This is from your surveillance cultures. And finally, you should have your own local antibiogram at your hospital and review it every time, every quarter, every 6 months, every 1 year. It depends about your local antibiogram at your unit. So those are the steps usually when you gonna use antibiotics in sepsis to hit hard and appropriate. Think about the hospital factors related to the patient, as we mentioned. What are the clinical syndrome you are treated? It's soft tissue infection, it's abdominal sepsis, is a meningitis. What are the most likely organisms involved? It is MRSA, it's MDROs, it's gram-negative. What are the risks factor for resistant organisms, as we mentioned before? Reviewing the BD key factors, pharmacodynamics, obesity, if the patient on RRT, on ECMO, so it's very important. At the end, you should use the antibiotic according to those 5 pillars. Also, one part of your job is to know the coverage who is covering gram-positive, who is covering gram-negative, who is covering anaerobes, and who is overlapping. And this is for each time you have to refer to your patient and local sensitivities, which is the local antibiogram. Combination or monoantibiotic therapy. Also, this is very important. But I will highlight because the combination therapy is defined as use of two different classes of antibiotics with activity against a single pathogen, mainly for two reasons: to accelerate pathogen clearance and to warrant pathogen susceptibility to treatment. What is the advantage, theoretical advantage of combination therapy? Broader empirical coverage, synergistic effect, decrease the risk of resistance. But what are the theoretical disadvantages of using combination therapy? Increase the risk of toxicity, renal failure or liver failure, increase the exposure of antibiotics, also driving resistance, collateral damage to commensal flora, and of course, to increase, okay, just 3 minutes, and increase the, of course, the cost. The best available evidence in ICU patients, this is regarding the combination therapy. The duration, the shorter duration of antibiotics, of course, prolonged duration of antibiotic therapy is associated with increased resistance. Disregard the special situation like endocarditis or gram-negative meningitis, stomatitis. Prolonged antibiotic therapy has not been demonstrated to be beneficial. We have a lot of evidence, 2013, 15, 18, that shorter antibiotics is the best. This is what the literature said. And we need to individualize the duration of antibiotic therapy, yes, because the severity of illness and clinical response, type of infection, deep-seated or MDRO's coverage, of course, source control, availability of the diagnostic tools like clinical and clinical scores and biomarkers, the escalation of the antibiotics, meaning going the empirical antibiotic therapy to the tailored therapy, is considered essential to have a successful antibiotic stewardship program. And usually this de-escalation practice, it focuses on reducing the antimicrobial resistance and the adverse related effect. And also we have an evidence base that de-escalation therapy is one of the safest and effective practice in managing the septic shock. It is estimated that in US, Europe, about 11 to 55% of treatment are de-escalated only, so about 50% still they are non-compliant. The main barriers for de-escalation practice: fear of patient deterioration, fear of patient being colonized with other organisms, facing management struggling when the patient have culture negative sepsis, and the lack of local policy or local guidelines. Biomarkers, just all of us, we know about the role of procalcitonin, but the problem with the procalcitonin, yes, it's more specific than CRP, but the beneficial effect of PCT-based algorithms have been demonstrated in critically ill patients. Also the CRB, but in most cases of septic shock, PCT level, as Dr. Hisham said, less than 0.5 or decreased by 80% of the highest BCT level has been observed to have a useful support in the clinical decision of stopping antibiotics, while also predicting favorable outcome. But again,
time,
yes,
please.
Okay.
Time, please.
So just to have some take-home messages with the next 3 slides, the only definitive treatment for sepsis is antibiotics. All other intervention guide treatment are supportive care. There are no linear correlation between mortality and time to antibiotics, as we mentioned. It's still debatable. The longer it takes to get antibiotics to patient sepsis, the higher their risk of mortality and morbidity. The risk of mortality for someone who progresses for septic shock is upward up to 50%. And remember, the mortality risk goes up to 8% for each antibiotics delay. Give them early and broader antibiotics should be followed by rapid, responsible de-escalation. As long as the causative pathogen is covered with a single empirical therapy, additional agents will not give any additional benefit. Optimizing the antibiotic use to improve the patient outcome, optimize the antibiotic use to minimize the pressure on emerging antibiotic resistance. And this is the final slide, just reminding you about the 5 pillars helping you in choosing the antibiotics: the patient-related factors, the clinical syndrome, and the most likely organisms, the risk of resistance, and PDB. And thank you, and sorry for delay.
Thanks very much, Prof. Adel, for this informative lecture. It's very wealthy, enriched with evidence-based medicine, included a lot of physiological, pharmacological, as well as pathophysiological data, which we should all, at least as an intensivist, get back to when dealing with our patient. Thanks for introducing the matter of the minutes matter. You highlighted it very well. Just because we're running a bit late, so we're going to take only 2 questions. So, 2 questions here is about de-escalation of antibiotic, especially with multi-drug resistant, and another question that's a bit related is, as well as with implementation of antibiotic stewardship. Should it be applicable in all institutions? In UK, for example, there is a discussion between micro and intensivist. Should be the case with each hospital? It should be a discussion individualized for each patient. So just to highlight these 2 questions as possible, please, and we move to the next lecture after that. Yeah.
Thank you, Dr. Mohammed. For the first question regarding the MDRO's coverage, yes, this is one of the fears usually when we start the practice of de-escalation, that for how long should I continue the antibiotics? On one side, that shortest is the best, like the practice 7 to 10 days. On the other hand, this is a multi-drug resistant. Once I de-escalate, the patient will crash, or the patient became more colonized. So now the recommendation usually it comes, or the best available evidence when we have a multi-drug resistant or MDROs or XDROs, now they are extending up to from 10 days to 2 weeks, not 7 days. This is based on the clinical condition of the patient, the clinical response, more important than the biomarkers, more important than other factors. So that you are bedside and you are the one who can judge this patient is improving or not. So you can extend again those guidelines or those recommendations, just guiding you. But if your patient is not improving, just you have to revisit again your source control. You have to readmit the BD key, the dose optimization, all the pillars of your antibiotic choice. This is mainly for MDROs. It's not simple like or just covering surgical prophylaxis. Is MDROs usually, or XDRs or BDRs usually, is one of our nightmares in the ICU. Second question is regarding the ESP or the antibiotic. I agree with you. Usually in our hospital, we had this practice like for more than 5 years. It's very successful in reducing the resistance and very successful in giving the antibiotics early. This team usually is very effective to manage patient, usually in the ER, RRT, and ICU. As you mentioned, Dr. Mohammed, that it's a team, it's a multi-professional ICU, clinical pharmacist, microbiologist, and infectious disease. And they published last year in 2019 or KMC a very interesting cost reduction regarding the empiric use of broad-spectrum antibiotics and antifungal, and it would reduce the cost by almost $300,000 in 1 year.